Okay, let's switch topics and we're going to talk a little bit about the immune system over the next 2 weeks. So what's amazing is over the last 30 years, the knowledge of the immune system has just grown like tremendously. For centuries, we actually knew what the immune system did. Even ancient philosophers from Greece and Rome would notice that people that got a disease or an illness, when they got over it, as long as they lived through it, then they were more resistant to it the next time. They didn't get it twice. They noticed that warriors coming back from foreign wars would pick up these weird diseases. If they lived through it, they didn't get the disease a second time, so they made great warriors again. So we knew what was happening. We just didn't really know how it worked. And when I was in school, I think that the textbook's most significant changes in medical textbooks was actually over the immune technology. We didn't know all that much about how things worked, and it was a popular thing to study the immune system and understand how it worked. And it's amazing because now that we understand it, we can actually use the immune system in all kinds of technology. So we use it to understand things like forensic science, like criminal forensics. We use it to detect diseases. We use it in cancer treatments all over the place. So our information about the immune system has grown so much, it's just amazing. And your immune system has actually developed over thousands of years to be such a sophisticated, sensitive, organic machine. In fact, it has these little tiny organic particles that can detect other particles that are so small, even very expensive technical machines can't detect them. And what's most amazing is this is something that's naturally built into you, that you have these tools. So let's talk a little bit about that. All right, so the first thing you want to know are the 3 lines of defense. And you can subdivide them into the non-specific and the specific. The non-specific would be the first line of defense, which is your physical and chemical barriers, like your skin and enzymes that you release onto the surface of your skin, like bacteria fighting lysozymes that are in your mucus. The second line of defense is if something penetrates the first line, so if it gets through your skin, like through a cut or a blister or a sore, then you have these cells in your body that come and attack it, and they trigger something called the inflammatory response. So we're going to talk about that a lot in this first section, the inflammatory response. And then in the next video or the video after, we're going to talk more about the specific, which is the third line of defense, and this is adaptive. This is something that you learn. These non-specific, they're there to fight off everything. Skin is there to keep all the invaders out no matter what the invader is. The second line of defense doesn't care what got past the skin, it will attack it, whether it's a splinter, or it's a piece of bacteria, or it's a piece of peanut oil. It doesn't care. The second line of defense will attack it regardless, but the third line is very specific to the invader. Like I said, we'll talk about that in better detail. So first, let's talk a little about that first line of defense. Okay, so we call it the innate resistance because it's born in you. It's something that you just naturally use. It would be the skin, the lining of the GI tract, tools like sneezing and coughing, and equipment to get things off of your skin, out of your body before it penetrates in. We also have biochemical barriers like antimicrobials, and I mentioned it on the last slide just a little bit. Your mucus and your skin actually secretes chemicals like lysozyme that digest bacteria. And you've seen lysozyme when you talked about the cell before. It releases things like lactic acid that make the pH a little bit different so that bacteria doesn't live so easily. We make earwax that's supposed to be an insect repellent so that insects don't want to crawl into your ears. But sweat, mucus, saliva, they all have these like antimicrobial properties to them. And then another interesting thing is that in your GI tract, you actually have this natural flora, these microbes that live inside of you and help take care of you. And we'll talk more about that when we get to the infection section. But the first line of defense are the physical and the biochemical barriers. Right? Here's a disorder that's damage to that first line of defense. So pemphigus is actually a blistering disease. It's an autoimmune disease where your own immune system attacks your skin and it causes these blisters all over the place. So there are actually 4 subtypes, and one of the subtypes is a paraneoplastic symptom of cancer. So it's something that's a byproduct of cancer activity in the body. It's kind of interesting to look at how this works, but you can see here's the layer of the skin, the outside layer. You've got the stratified squamous epithelium. Down here you have the connective tissue, so the dermis, and then the epidermis up here. And look at this big pocket. This pocket's filled with fluid and it actually peels off. It's called acantholysis. And that's talking about where the desmosomes that hold these connections together are weakened, they get attacked, and they break apart. So you can't hold your epidermis to your dermis. And so you get these blisters of fluid that build up. And then the skin can peel off and break. And unfortunately, this epithelium is there to protect and keep bacteria out. So now bacteria can get in. So pemphigus vulgaris is a common one that you see on like mouth and mucous membranes, and also the genitalia. So what happens when that first line of defense is breached? So let's talk about inflammation. You get the typical signs of inflammation: heat, redness, swelling, pain, loss of functions. So you've heard all the different terms like rubor and power that define these things. But when you get any kind of a penetrator, whether it's a splinter or a bacteria or even physical damage to this tissue, if you smash these cells and you damage these cells, there are a couple events that happen that lead to all of these symptoms: the swelling, the redness, the pain, and everything. Accidentally skipped over. There we go. So, and also, if you notice, in a lot of these black boxes, I actually put questions. So if you're going through and studying, you could ask yourself, define inflammation, stating the major benefits of the process, and then just cover these up down here and see if you can answer this appropriately. So what inflammation is: first, local complex biological response to vascular tissues from harmful injury, infection, or irritation. So it doesn't have to be a bacteria or a virus getting into you. It can be anything. So it can be a toothpick jammed under your fingernail. That can just trigger inflammation. Right? It's initiated by lots of things. It can be initiated just by cell death. So necrosis of that tissue dying rapidly for whatever reason, whether it's a toxin in there or something. If that tissue's dying, it triggers inflammation. Right? And then the benefits: limited tissue destruction. So it kind of isolates off the area. It increases blood flow to an extent to bring in healing factors, but then it decreases the blood flow downstream so that the infective agent or the problems don't spread downstream. It isolates the infection, then it also triggers healing. We'll talk about some of those things. There are really kind of three major steps that happen. And those three major steps revolve around chemicals called cytokines. And we'll talk more about those in detail as we get through this section. But when you look, the first thing that's going to happen is wherever the damage is at, you get this blood vessel dilation. So the blood vessels open up. Normally you can see the blood vessels are really close together and they have little small pores. But when you have damage, they open up wide enough so things like white blood cells can seep through. Water, fluids, plasma can seep through. Some red blood cells might seep through, and some proteins. So vessel dilation is the first thing. And then you get the permeability, the fluid leakage, and then the last step is actually white blood cells moving in. And we're going to talk about each of those steps. And this is a picture from the text that you can use as a reference to come back to. Right. So first step, endothelial cell retraction is the technical name. Normally with endothelial cells, you can see they've got these little pores that are kind of tight together. They have tight junctions, but the little pores in between, so fluids can leak through. When we talked about edema, we talked about this a little bit. But what happens when you have damage to the tissue, you actually will retract these back so they look more open. More products can slide through. And those things that are sliding through are usually referred to as exudates and transudates. Transudates is when just plasma is sliding through, so it's just a fluid sliding through. Exudates when plasma slides through, but cells and proteins can also slide through too. So maybe white blood cells slide through, proteins slide through, and you know, if proteins slide through in here, they're going to pull water with them. So exudates are the plasma cells and proteins, where transudate is just the plasma. Right? So what do exudative fluids tell you about the inflammation? They can tell you a lot of things, and there are actually 4 exudates you need to get familiar with. And the first one's called serous exudate, and this is watery. The best example for this would be, sunburn. So if you have a sunburn, if you ever popped it, which you shouldn't pop it because then you're more susceptible to infections, but that sunburn has that really clear liquid in it. That's called serous exudate. It's very watery. The next one's purulent exudate, and purulent is when it has pus in it. So we call it purulent discharge. But that pus indicates there's bacteria in there. The serous exudate's signs of early inflammation, not necessarily infection. Purulent exudate is showing you that there's actually an infection, a bacterial infection. The next one's fibrinous exudate, and this is where you actually have clotted factors in there. So you've got infection, you've got thick clotting chunks. I always think of a pimple. You know, if you pop a pimple or a zit, you've got that thick white substance. That's a fibrinous exudate. So pus is when it's more liquidy and it pours out, but that fibrinous is when it's thick and dense, like in the middle of a pimple. And the last one, hemorrhagic, and the name kind of tells you what's going on. Hemorrhagic exudate is when there's blood in there. All right? So, of course, that indicates bleeding. I skipped over, but the fibrinous exudate actually is a sign of more advanced inflammation. So those pimples, when they get that thick, dense material inside of them, that's because that bacteria has been building up there, the white blood cells have been building up there for a while. And the main purpose of these exudates is actually to dilute toxins from the dead cells, to limit the use of that area, to carry cells into the area, and help carry toxins and wastes out. So there are a lot of purposes for these fluids. It's not just there to, to look ugly. Right? So the second major step, white blood cells are going to move into the tissue. So here you can see, here you see blood vessels. You can see lots of blood cells in here. Right? This is kind of a cool process. So fluid loss, as you're losing the fluid into that exudate, as it's getting lost out, the blood will actually thicken in this area. And as the blood thickens, these cells start cramping together, and the flow slows down through here. So what's also kind of interesting is the white blood cell will start grabbing a hold of the wall of the blood vessel. They'll start using little tools to grab a hold. They're called CAMs, cell adhesion molecules, and they stick along the wall and they slow down. So you see them floating really quick through the circulation, then they start slowing down and rolling really slow. I always imagine that those big four-wheel drive trucks with the big knobby tires. That's kind of what this is doing. It has these big knobbies on it that get good traction. They slow down and roll through here. So that's the next step. Oh, I don't know if margin. Yep, sorry, I skipped margination. So margination is the process of it binding to the wall and actually slowing down. It's called margination. Next is a process called chemotaxis. So chemotaxis, what happens is chemicals will attract cells to an area. And these cells work a lot like a bloodhound. If a bloodhound smells a rabbit and the rabbit goes running this way, as it's smelling the trail, it smells the chemicals from where the rabbit left its oils behind on the plants and maybe a little bit of butt stink or something like that. But this bloodhound will start following that thicker trail or that thicker concentration. So imagine this is your bloodhound. This is actually a cell, but you can smell that if the rabbit runs in this direction, there's the rabbit, the highest concentration of the stink. You've got a mild concentration here. So the bloodhound will sniff back and forth, smells nothing here, smells something here, so it moves this way. Smells back and forth again, smells nothing here, smells something this way. And it keeps doing that until it gets attracted to this area. That's chemoattracted, or chemotaxis. The same thing happens with cells. So these cells don't have a nose, but they have sensors on the surface, and they smell that concentration. And they move in the direction of the concentration. They actually grow something called a pseudopod, which is basically a fake foot, and it reaches out and it pulls itself in that direction. Right? So if this were the bacteria putting off all that stink, this white blood cell would be crawling in that direction trying to find that bacteria. This is actually an example. There's a white blood cell. You can see the bacteria here. And let's get this video playing again real quick. There we go. So you can see the white blood cell actually chasing after the bacteria. It's kind of interesting because it has to decide, does it want to go after that one or that one? This one must smell way better. And it chases after this. When it finally catches it, it engulfs it, just wraps itself around and swallows it and digests it. It's amazing. This is sped up really fast. So normally the white blood cell doesn't move that quickly and the bacteria doesn't move that quickly, but it's a really cool process. It knows where the bacteria is at, even though it can't see it. It smells its chemicals. Right? The next thing that happens is diapedesis. So that margination is slowing down. You're rolling along with those big muddy tires, and then eventually what happens is, if let's say that this is we'll say it's a monocyte. So this monocyte's rolling along here, and it slows down. It smells those chemoattractic chemicals, and it suddenly gets activated, and it merges in between the pores of the blood vessels, and it slides in towards the bacteria. Once it moves into the tissue, it's called a macrophage. And you've probably heard that. Macro meaning big, phage meaning to eat. So it's going to come in here and try and eat up all the bacteria it can. So there's the process again. You can see the capillary lining. You can see margination happening, and then diapedesis merging in. Once it finds the invader, the white blood cell goes through a process called phagocytosis. So with that macrophage, the name itself is telling you it's eating. So you're rolling down, you're slowing down, you go in through diapedesis, and then it works its way around like we saw in that animated video on the last slide or slide before. It finds the bacteria and then it wraps itself around the bacteria. We're going to talk about phagocytosis in better detail later. But here it's wrapping around, it's swallowing the bacteria, and then it introduces that bacteria to a lysosome where it digests it. And here you can see white blood cells and bacteria. Okay. So those are the basic steps of inflammation and bringing in things like white blood cells to help kill whatever the invader is, if there's an invader. There are also systemic effects. So when tissue is damaged or when the white blood cells are activated, they release chemicals into the environment. These chemicals are called cytokines. Cytokine basically means cell communicators. So it's one cell talking to another one. So these cytokines get released, they get released into the blood, and they can travel all over the body. They're going to go to the bone marrow, and they're going to introduce production of brand new white blood cells, like neutrophils, which are the first on the scene of the infection. So it goes to the bone marrow and cranks out more white blood cells. It's getting ready. It's building an army, a clone army. And then it goes to the central nervous system, and it causes you to want to get tired and kind of sleepy. We're going to talk about it stimulating fever on the next slide. So it's going to go to the central nervous system and turn up the body's heat to try and cook out the invader. It also goes to the liver, and the liver's probably the least likely player that you would think about. But chemicals go to the liver, and they start cranking out protective proteins. Things like fibrinogen that helps you clot blood so that you don't bleed to death. And things like C-reactive protein, which we'll talk about in a couple slides coming up. But there are effects going on all over the body when you have just a localized infection to the hand. Chemicals still get systemic. If you get a little bacteria underneath your skin, they're going to release chemicals into your blood that go to your brain and actually trigger things like a fever. So you automatically get a fever with that infection. It's just kind of a given that's going to happen. All right, so let's talk, actually, there's our first homework question. So C-reactive protein, or CRP, is released by the liver in states of inflammation. What you want to look up is CRP binds to what? And the word I'm looking for actually starts with a P. So it binds to something that's on the surface of dead or dying cells. Even some bacteria express this P word. So you're going to look it up. And that these C-reactive proteins also stimulate certain cells that are known as big eaters. I kind of gave that away with my big mouth in the last couple slides. But these C-reactive proteins are kind of like, if you ever see sharks swimming in an area, the sharks are pretty peaceful until they smell blood. The C-reactive proteins like dumping blood in the area. Now these big eater cells are going to come in. They're going to start eating everything in that area. So you look up what those are. And then they move in, they eat necrotic or apoptotic tissue. Right? So a lot of times when we suspect an inflammation, we'll actually do a blood test for CRP, and that tells us there's inflammation, but it doesn't say specifically where the inflammation is. It just gives you an idea that there is inflammation. But we also use CRP to indicate other things. So your job is you're going to look up those two words that are in the blanks up there, and then the next thing is you're going to look up what other disorders does presence of CRP at high levels in a blood test indicate. So go ahead and pause and write that down. All right, and then fever. So we left off right before the homework question with fever. So fever is due to infection and some toxins. Anytime you get toxins or infective agents in your body, you get some kind of a fever. It could be a low level or a low grade fever. It could be a pretty intense fever. Right? But there are a couple things that trigger it. One's exogenous pyrogens. If you look at the name pyrogen, it's telling you it's a fire generator. So exogenous pyrogens are coming from the bacteria. So it could be things like lipopolysaccharides, so in other words, lipid sugars on the surface of bacteria. They're unique to bacteria. When these get into your body has evolved with bacteria to know, hey, this is on bacteria. We've got to crank up the temperature of the body and try and kill this stuff. So that's one thing, exogenous proteins that come with the invader. Another one is that the white blood cells in your body, like the monocytes, macrophages, they make their own chemicals, and we call those endogenous pyrogens, because they're from within you. So the names for some of these are going to be things like interleukins, which we'll talk about in just a few slides. So they're released into the blood, they go up to the hypothalamus, and they actually trigger the hypothalamus to reset the temperature in your body. So damage to tissue, even without white blood cells being there, release chemicals like prostaglandins. And prostaglandins go up to the brain. In fact, your hypothalamus makes prostaglandins. And the prostaglandins will reset the set point of the hypothalamus. So if the hypothalamus is natural temperature, if you think of it like your thermostat in your house, if the natural temperature of the core of your body is 100 degrees, it'll say, well, we need to turn up the heat to cook the bacteria. We'll turn it to 101. And if you don't kill the bacteria at 101, you're still releasing these chemicals into the environment. It says, well, let's try 102. If you don't kill the invader at that point, you're raised a little bit higher to 103, and then 104, and then 105. When you hit 110, you die. So it'll keep heating up trying to kill the bacteria, even at the expense of possibly killing you. It just knows that if you let that bacteria live, there's a higher chance that you're going to die. Right? So I already kind of mentioned this. The hypothalamus' set point changes, and the hypothalamus regulates homeostasis. And you already know this because I know whoever taught you physiology, whether it was me or somebody else, beat you into that, to the ground with the hypothalamus and regulating things like freezing and fighting and feeding instincts and all of those things. So homeostasis. What the hypothalamus does is it will release TSH, thyroid stimulating hormone. well, actually, you know the process. So it releases TRH, which goes to the anterior pituitary, releases TSH, and TSH goes and releases T3 and T4 from the thyroid. But if you remember from your physiology class, T3 and T4 raise metabolic activity and raise the temperature of the body. So it raises your temperature in your body. Right? The hypothalamus is going to stimulate the release of ACTH, also comes from the anterior pituitary, and that releases glucocorticoids. So the glucocorticoids are going to come out and they're going to help raise the sugars in your body to fight the infection. And glucocorticoids, remember, are stress hormones. So they start adapting you for the stressful response. Right? Next, it causes the release of epinephrine. So it's going to change your blood vessels, blood pressure, and it also raises the production, decreases the production of ADH, so antidiuretic hormone. If you remember, antidiuretic hormone helped you retain water. So if you decrease ADH, that means you start urinating more, you start putting more fluid out into the environment. So those are just some of the effects of the hypothalamus. There are some benefits to the fever, and I already mentioned it. Cranking up the temperature kills the microorganisms. So our body has evolved to know that hotter temperatures, the microorganisms, they can't adapt very well. When you heat them up very high or cool them down very low, they don't have a fur coat or very good protective mechanisms for temperature, so you're more likely to kill them. This is interesting too. When you change the temperature of the body, you actually change the levels of iron, copper, and zinc. Those are things that are needed for the bacteria to replicate. When you change the temperature, they're not as easily available. They bind to other things in your body better so that they're not available for bacteria. What's kind of also interesting, and I think I put a homework question about this, is zinc. Low levels of zinc are bad, but high levels of zinc are bad too. And I'll have you look that up. So chemicals like Zicam, their effects on bacteria. Right? And then it also causes lysosome breakdown. So cells, when they get too hot, the lysosomes burst and they actually start destroying the invaded cells. So if it's a virally invaded cell, boom, it starts eating the virus and eats the whole cell so the virus doesn't spread. And then it increases leukocyte motility. The warmer the temperatures, the more active the leukocytes become. So basically it's like warming up the water for the sharks so they move nice and fast. They get really stimulated and irritated and they're more eager to attack and kill things. And then enhances phagocytosis. Right? We're going to talk about interferon in just a few slides. Right? So now that you've increased blood flow to the area, you've caused that puffiness, that endothelial retraction, you've brought white blood cells in, you've cranked up the fever just a little bit, the next thing that's going to happen is you're going to start blocking off clots. So you're clotting the area off so you don't bleed to death. And this is kind of overlapping with the other two, but what's going to happen is the damaged tissues actually release chemicals, cytokines, chemotactic factors, things like that, that bring white blood cells in, but they also release chemicals that cause platelets to turn on. And these platelets start clumping, so they're going to start clotting together. Chemicals like adenosine diphosphate, so ATP that's been used actually helps stimulate clotting. Serotonin affects the blood vessel walls, the smooth vessels, and constricts them down to try and isolate whatever the infective agent to that area. It also helps, in case you're bleeding, it helps prevent blood flow from going out and bleeding to death. It'll release things like VEGF that we talked about in the cancer section. So it's going to stimulate new growth to that area because it knows this tissue is damaged. It's going to start growing this new pathway. And then they'll bring fibroblasts in. The fibroblasts will start rebuilding the tissue. But a couple chemicals to get familiar with, we're going to talk about kinin, the kinin cascade. The kinin cascade actually shrinks endothelial cells, and bradykinin specifically stimulates pain. So kinins are a pathway, and bradykinin is just one of the steps in the pathway. Next, the prostaglandins constrict the smooth muscle, like we talked about with serotonin too. So platelets release serotonin, and the cells release prostaglandins to try and constrict that tissue. And these also can stimulate pain, like prostaglandins can stimulate pain. But a lot of these chemicals are referred to cytokines, so chemicals that talk between cells. So once you've blocked off that flow, you've got your inflammation, you've got some damage. So let's assume that you damaged the tissue. So you can have resolution or repair. Resolution is kind of the ideal because resolution means you regenerate that tissue and it grows it right back to new. Tissue that's barely injured is going to grow back to the way it was originally. It's easy to fix. But when you have extensive destruction of tissue, you have to go through this process of repair. And repair, usually you're laying down brand new collagen, but it's not like the old stuff. So you don't get exactly the same type of skin you originally had. And a lot of times it will actually lead to a scar, which we'll talk about. So sometimes you'll be asked to describe tissue healing by primary or secondary intention. The key here is primary intention are are minimal wounds, so minor wounds like a paper cut, even a surgical incision. The fibers in your skin go certain directions, and surgeons know those directions, so they try and go with the fibers so that you heal better and you don't get such a bad cut. But those are considered primary intentions, things that heal relatively easy. Secondary intentions are things that require a lot more repair, like stage 4 ulcers or massive necrotic tissue areas and things like that. And over here you can see the breakdown of the time, the average time for healing, and the different things that happen. So like within 3 to 24 hours you can see lots of neutrophils moving in. And these neutrophils are white blood cells that come in and try and eat the bacteria and attack fungus. Next, you're going to have macrophage moving in. So within the next roughly 40 to 72 hours, the macrophage will come cruising in, and they're there to clean up all the dead debris. So you've got these neutrophils that come in as soldiers, and they kill everything in that area. In fact, when you're looking at pus, you're seeing primarily neutrophils. So all the white, the white pus-looking substance, the purulent discharge, those are neutrophils that have eaten so much, they've killed so much bacteria, and then they die on their own. So that's the pus. Macrophage come in and they try and eat up a lot of that debris. This battlefield, they come in and they clean up all the dead soldiers and they try and clean the area up. That's a macrophage. And then about 5 days in, you start getting intensive healing. Like the fibroblasts are coming in. And fibroblast means fiber maker. So they're laying down this thick collagen. They're trying to repair things the best they can. Right? And within the first 2 weeks, you've got lots and lots of this, what we call proliferation. So replication of fibroblasts, making tons of collagen, and within 2 months, you actually have completely repaired. But you have a process called remodeling, which I'll show you in the next couple slides, where the remodeling is taking that old stuff and just kind of like cleaning up and making it more like it was originally. So here are some of the key players that you're going to see: neutrophils, things like fibroblasts that come into the picture. And we've already talked about processes like diapedesis and margination, how they get in there. Right? Next, when you're talking about the phases or the major phases, some textbooks numbered them, but I've found that there's so much inconsistency, don't even worry about numbers. Like some books say there are 4 major phases, some say there are 3. Here's the big picture you want to look. In the beginning, your initial healing, you have this filling process. So I already talked about it a little bit. You get fibrin that clots up the blood so it doesn't bleed out. You have platelets that are helping release things like serotonin that constrict blood vessels. The red blood cells are in there bringing oxygen to the environment. Then you get this sealing phase. And granulation is when you're adding all this like structure around to isolate the tissue so that nothing can leave. So granulation usually happens about 5 to 7 days, and that's because of fibroblasts. And then you have shrinkage. What's interesting is that in all of this tissue, you actually have actin and myosin. And you know from the past, when actin and myosin touch each other, they start contracting. So you get this wound shrinkage. And it pulls different sides. So if you have a cut on this side and this side, this actin and myosin that's in here, in like the platelets and the fibroblast material, they start contracting and they'll pull this side towards that side. So they start pulling together, this contraction phase. And then debridement is when you're breaking down the clots, you're breaking down the debris, is the way I like to think it, and you're trying to rebuild this tissue. So when you're remodeling, what's interesting is you get that scab on the top. If you peel the scab off, you actually have this dent underneath and this nice pink tissue. But then a couple months later, you see that this tissue starts turning white and it starts tightening up and it actually pushes the skin up. As this contracts together, it pushes the skin upwards. So you're remodeling up to 2 years after an injury. And that's why in the first year, roughly, that scar is kind of pink and a little bit sunken, but after that, it's usually more of a raised and more pale scar. And what really sucks about scars is that they look thick and dense, but in reality, they're only 80% as strong as the original skin. So scars are typically at their best strength within 10 or 12 weeks of the initial damage, but they're never as good as the original skin was. All right, and then here's how your book breaks it down into 2 major overlapping phases. So here you have a reconstructive phase where you're using the fibroblasts, you're making lots of collagen, you're putting down new epithelial tissue. So the cells over here replicate, and these are all epithelial cells, and they just keep replicating until they meet up in the middle, and then they fill as tissue. And that contraction, it contracts about 0.5 millimeter every day, so it's pulling and pulling and pulling. And then the maturation phase, like I said, can take up to 2 years. So after a few weeks, you start remodeling all this stuff underneath. You start cleaning up all the remnants, all the debris that was left behind, and you're trying to make it into a stronger tissue. All right. So next, describe the different types of dysfunctional wound healing that can occur. When you're looking at this, all of these things actually have one thing in common. So all of these, you disrupted the healing process. So if you're hemorrhaging from that cut, you're not allowing all that healing factor to stay in the area. You're actually bleeding it out of your body. Fibrous adhesions can actually block blood flow and keep the white blood cells from getting there. Infection, if you're busy fighting bacteria, you're not making time to actually repair the wound. So things like wound sepsis can happen. Hypovolemia, decreased blood volume. If you're not getting good volume, you can't get good flow into the area. And the hypoproteinemia means too low of protein in the blood, so low protein blood. Those proteins are usually important as clotting factors. So go back up and see hemorrhage. If you can't clot properly, then you just keep bleeding. And then things like anti-inflammatory steroids that turn down or dumb down the immune system so they don't know what to do. But all of these disrupt the healing process, and I'll show you some examples of what could happen. So here are some things that could be an outcome. You get impaired collagen matrix assembly. So specialized scars. We know a typical scar, they're not pretty, but these are kind of special abnormal scars when the process doesn't work appropriately. So the first one's called a keloid. And a keloid's trait, let's say that you got your ear pierced. That's a little tiny poke, but look at this scar that came out as a result. The trick with keloids is that keloids, they grow beyond the borders of the initial injury. So if the initial injury were just a straight line like this, a keloid may go way over here to this side and way over to this side and then grow really tall. They're over-exaggerated scars, basically. And that's what a keloid is. You can have a hypertrophic scar. Hypertrophic scars are not the same as keloids. Hypertrophic scars typically stay confined to where that initial injury was, but they just go straight out. So they come out at you. Instead of going broad and wide like this, they actually just raise. They're a raised scar. So they look kind of similar, but their definition is based on how they're growing compared to the original insult. And then here, impaired epithelialization. So the tissue doesn't get a chance to heal back together. Things like anti-inflammatory steroids or hypoxemia, so not enough oxygen in the blood. Your cells need oxygen. If they don't, then they die. Things like nutritional problems or diabetes can do this too, impaired flow to the tissue. So here you can see a massive grade 4 ulcer or stage 4 ulcer. And then in other situations, impaired contraction, like contracture. Contracture is used in different ways in different examples. Like we'll talk about contraction when it comes to muscle later too. But this is when we're talking about the skin. This kid had a lot of burns, and when his burns healed, this is his range of motion. He can't lift his arm above that because all of this tissue became scar tissue and healed inappropriately. I know in some of the wars when people would get burned, what they learned to do is they would actually stretch their arm every day to stretch that tissue out so it would heal, giving them full range of motion. So you want to know keloid scars, hypertrophic scars, and contracture as major issues. And then this is the last one, the wound disruption. And this is called dehiscence. So dehiscence is when you've had a suture, you've had some kind of repair, and something forces that stitch to be pulled apart, like excessive pressure. Manly men that want to get back to work really quick, and so they don't have time to be slowed down by scars, and then they go out and they overexert themselves and they rip their tissue back open or rip their stitches open. This is an example of dehiscence. So the wound pulls apart at the suture line. And one of the common causes is actually obesity. So too much body fat in here impairs blood flow, impairs healing, and it can also put more stress on the skin and re-rip open the tissues. So homework number 2, other than obesity, what are 2 really common causes for dehiscence? And that's the end of this section. Go ahead and hit pause, write the question down. You can Google that, and we'll see you on the next video.